Thank you so much. I am a pelvic floor PT based in Southern California. I've been practicing for about 17 years now. And over the years, I've definitely seen a lot of women, a lot of patients struggling with LS. And you guys inspire me. Thank you, Cecilia, for sharing a little bit earlier. I'm honored to be here today. So thank you for all being here too. So we're all familiar with what LS can look like. And for those of you who live with it, know how it feels like as well, yeah, emotionally and physically. So, but what happens when those visible symptoms have resolved, when you're not in a flare up and you have these lingering bowel and bladder issues? In my practice, when our pelvic PT practices, it's an invisible illness. You know, you look just fine on the outside and you're struggling with these things. So they're not normal, super common, but not normal. And you don't have to live with them, and you can learn how to better manage them. So that's where we're going to talk about the most common ones that you might be experiencing and how you can better manage them on a day-to-day basis. So just briefly, I mean, you all know this, I don't really have to tell you this, but what is lichen sclerosus? By definition, chronic inflammatory dermatosis. It can involve scarring of the vulva, often sexual dysfunction, pain, and it can present in males as well. But in my practice, I've not yet seen a male come in for treatment. It's already underreported and undertreated. So the stigma that you guys have experienced, imagine that for a male, you know, to be even talking about that, it's real difficult. So again, I applaud you for becoming more aware, and let's normalize these kinds of conversations. Physical manifestations, as you know, clitoral issues, introitus, right at the opening from the vulva into the vagina. And you can get fissures, scar tissue, plaques, itchiness, so lots of chronic inflammation. Etiology, still quote unquote unknown, but I think the general consensus is that it's becoming more of an autoimmune issue. It occurs a lot concurrently with other autoimmune issues, especially, Graves' disease, hypothyroidism. It does often present more in women, and it can take 5 to 15 years from symptom presentation to diagnosis. That's a long time, often, again, underrecognized and underreported. Diagnosis upon physical examination and biopsy. So in general, prevalence, it's affecting about 1 in 70 women. There are spikes where diagnosis is more common when there's hormonal changes. So in younger girls, right before their periods, and then in perimenopausal women, up to 40% will display onset in their reproductive years. So there are also some very specific comorbidities or concurrent symptoms that people report when after or during their LS diagnosis. Bladder dysfunction, including overactive bladder, incontinence, stress incontinence. The difference in this study is incontinence was reported on a survey, and it was just general urine leakage. Stress urinary incontinence was reported upon sneezing, so leakage upon sneezing. So this was in this particular study, but pretty high occurrence in a lichen sclerosus group, 38% for general incontinence, 27, almost 30% for stress incontinence, and then bowel dysfunction, IBS, but constipation, over 30% of women experiencing that. And of course, the more obvious and common vulvar pain, the thyroid dysfunction, even TMJ and fibromyalgia. So just these like global systemic pain syndromes that you might be experiencing. You're not alone, and it can be very frustrating. So let's talk a little bit about the impact. So the impact, these things that we're talking about, really what we're concerned about is how it's impacting your quality of life and your ADLs. So I'm sure you're familiar with these terms, QOL, quality of life, ADLs, activities of daily living. Toileting issues that we'll be talking about today, pretty high on that list of affected ADLs. So let's get into talking about bladder dysfunction. So overactive bladder, defined as the urgent and frequent need to empty the bladder. Lots of other symptoms, but that's the general definition. So I'm curious, let me ask you the first question. Who has experienced overactive bladder since their LS diagnosis or worsening since your LS diagnosis? So if you could go to your poll platform and let us know. So you can have overactive bladder with incontinence. So for example, my patients, a lot of my patients, they're sitting at their desk or they're doing a task and they're very still and they make a little movement and all of a sudden they have this urge to go. Oh my gosh, I gotta go. So they have that sudden urge to go, they try to make it to the bathroom and they're leaking. So there's their incontinence with that. Without incontinence, you can just have that more frequent and urgent feeling that you have to go, but you can make it to the bathroom. And then of course, there's some lucky ones without any bladder symptoms of urgency and frequency. So yeah, looks like 40% without, 30% with. That's a lot of you. So get the last answers in, I think. Good. And let's dive deeper into bladder dysfunction. Oh, poll not yet ready. Okay, so stress urinary incontinence, another big one, defined as a loss of urine with coughing, sneezing, lifting, any increase in intra-abdominal pressure. It could be just a few drops. It could feel like a really full bladder emptying. And there are two types. One is due to urethral hypermobility, where the urethra shifts positions and due to this increase in pressure and you leak. And then there's the intrinsic sphincteric deficiency, where those internal sphincter muscles that keep you continent are not able to hold the urine in the bladder appropriately. I feel like most people with SUI have some issues with some degree of this sphincteric deficiency. So another question for you, go to your polling platform. How many of you have experienced SUI following your LS diagnosis? 100%, 93. So in that previous study, we looked at, for prevalent, it was about 28% of the LS patients that were dealing with stress incontinence. But for us, 67%, that's a lot of you. Pelvic weakness can often be the culprit, but it's not usually just as simple as just do Kegels. So we'll talk about that in some upcoming slides. So last answers in. And let's take a look at bowel dysfunction. So constipation, a big one of the most commonly reported, defined as having less than 3 bowel movements per week, hard, lumpy, dry stools that are difficult or painful to pass, and the feeling of not all stools passing. So like that feeling of incomplete emptying. You don't get that like, I'm empty after a bowel movement. So another question for you, how many of you have experienced symptoms of constipation? So go to your polling platform again, let us know. 16 out of 100 adults are reporting symptoms generally. Again, in that previous study, there's 33% of the LS group that was reporting constipation. And I'd say in my practice, there's upwards of 80% of my patients. Now, I don't see everyone doesn't have LS. Not all of my patients have LS, but they have some sort of pelvic floor dysfunction. And about 80% of my patients have reported constipation all their life. So it is definitely very prevalent. And I'm glad that the majority of you are not experiencing this. But let's talk about why these bladder and bowel issues might be happening. So you might be asking yourself why, not just, oh, well, I had LS and that's what happens. There are reasons why things happen. So a couple things: nervous system overdrive, where you're stuck in a fight, flight, or freeze response, and an actual mechanical fascial connection due to the initial, irritation, inflammation, and scarring from LS. So the autonomic nervous system is composed of two parts: the sympathetic nervous system, where we've heard that buzz term fight or flight, response, and then the parasympathetic nervous system that's responsible more for resting and digesting. Many of us in general are stuck in this fight or flight response just with our average ubiquitous nature of stress. You ask somebody, how are you doing? Oh, I'm busy, I'm stressed, and we move on. I say that all the time, and recognizing that it's not normal. We've made it normal, and it's not a good thing necessarily. So keeping, in general, that's the average person. Now, for an LS patient, going back to that previous, the numbers of 5 to 15 years of being misdiagnosed, not heard, not validated. If you think about it, especially dependent on the severity of your symptoms, that is trauma. That's a lot of perceived trauma. So it can take, that's a long time to be traumatized on a daily basis. And it's pain with wiping, pain with intercourse, the stigma of what your vulva looks like, the feeling that something's wrong with you and you don't know what to do, not having any answers. That can all be considered trauma. So now you add this chronic pain syndrome to a person, an average person, already in fight or flight response, and you have these external issues that are gone, but that perceived trauma, stress stays. So now every time you need to go to the bathroom, you may be anticipating it'll burn or that it'll hurt when you wipe. Every time your partner initiates intercourse, or intimacy, you might be anticipating it'll be painful. And our response to that is to tighten up further, which then restricts blood flow further, increases cortisol. This increased tone and pressure from the muscles actually tightening up. Now, this is subconscious. You're not even necessarily doing this on purpose. You may not be aware of that. And these can all contribute to these bowel and bladder issues. So we really need to do more to activate our parasympathetic nervous system that encourages that rest and digest, the release of that blood flow from our important internal organs to just the whole body, so we can relax, increase digestion, and help with voiding. Now, I know there was another presentation, the amazing Ashley Crew from day one. So if you guys want to listen to that replay, she'll talk more about, if you want to nerd out on the nervous system and stuff, that's a really great resource. So this was just a little nutshell. So now the other part, the mechanical part, the fascia connection. So I'm sure you've all heard about fascia. It's a thin layer of tissue that lies under our skin, above our muscle, and it's like a bodysuit that we're wearing. It connects our visceral organs, our other tissue, all of our systems. It's like a little bodysuit spider web thing. And the bottom line is that everything is connected. So little tears or cuts in the skin, for example, lichen sclerosus, plaques, or when you get a fissure, the skin cracks, that can actually affect the tissues around it, but also then below it. So this fascial layer. There is an actual direct connection between the adductor fascia, the muscles of the inner thigh, and the lower abdominal fascia. And what lies in between that? Your pelvis, your pelvic floor. So your bladder, your bowel. And fascial scarring, even at a skin superficial site, if untreated, can actually affect the deeper tissues, your bowel, your bladder, and eventually directly mechanically affect your central nervous system. So what can we do to be kind to our bladders? So we'll be going through this list in detail, but first things first, don't rush and don't push. So it can take 13 to 15 seconds to empty your bladder, up to 20 if you have a really full bladder. So take your time. This rushing around, this, you got work, you got the kids, you got the animals, and I gotta go, we gotta go. It's really not helpful. So I'll encourage you to slow down. You can void up to a full bladder can hold an average like 2 cups of liquid. So imagine that slowly coming out of your urethra, and just take your time, breathe, sit down, and just let it flow. So this was interesting, the Köbner Phenomenon. It specifically talks about, we can go to the next slide. It specifically talks about the skin alterations, so things like psoriasis, but also lichen sclerosis. So this is the clinical takeaway is that tight clothing, mechanical irritation can trigger or worsen these LS symptoms. So trying to stay away, which is it's obvious, but I have a lot of patients that will, when they're having a flare, go without underwear. They'll stick with long skirts and long flowy pants where the crotch is way down away from the vulva, and that's what makes you more comfortable watching rough toilet paper, hard sitting surfaces. So a lot of my patients also have installed bidets. That's a lot more accessible now. So it cuts down on the need for wiping. You can kind of rinse off and pat with a towel. Lots of interesting things, like you can just hook up to your toilet and everybody can have a bidet. So that's a couple things that my patients have been doing lately. And then another important tip is drinking enough water. So it might be counterintuitive when you're experiencing bladder issues, especially leakage, to kind of withhold your water intake. Maybe doing that just subconsciously, but water is really necessary for healing and tissue health. So there's a large range of normal hydration with differing water intakes. There's a survey that I came across. It was like between 19 and 30-year-old men and women. And it looked at just total water intake. So 3.7 liters for men and 2.7 liters for women, but that was inclusive of the water that comes out of your food as well. So in general, the actual liquid, they estimated somewhere around a little over 100 ounces for men and about 72 ounces for women. And that's water and other liquid beverages. So a general rule. It varies for everyone. And then if you have other medical issues, there's sometimes you have to limit your water intake. But barring that, water is very important. So you can use this urine color chart to give you a general idea of where you're standing. It's hard to get enough water in and then not, say, run to the bathroom every hour or not wake up at night, more than once. So definitely stop drinking fluids 2 hours before bedtime or so to avoid waking up at night. I tend to front load my water. I shoot for a gallon a day. It's a lot, but I will try to get 32 ounces in before I even start work. So it sets me up for success. I can kind of sip on the water the rest of the day and get everything in before the evening time. So with all that water intake, you're definitely going to be going to the bathroom more. But it does make a difference on how you sit. So firstly, sit and don't hover. So when you're hovering, it can actually limit how much you're emptying. Sometimes you can only empty a third of your bladder for some people if you're hovering, which we've all done, I'm sure. So I suggest using toilet paper to line the seat, or even bringing your own seat covers. I have patients that purchase them so they have them all the time for public toilets, and you can actually feel comfortable sitting. And of course, the feet ideally would be flat on the floor. If you need to raise the floor up so that your feet can be flat on the floor, you can use a squatty potty similar to this. You don't have to buy a squatty potty. You can use step stools from home. You can use phone books. You can use anything to build that floor up to get your feet flat so you can completely relax. There's a couple of additional things you can do to help empty your bladder. So non-invasive bladder draining. I don't know if you guys are familiar with the Kegel maneuver, but using both hands, you're gonna place, usually one of them is in a fist, over your bladder right above your pubic bone, and put the other hand over that. You lean forward and pressing down toward the pubic bone to kind of wring out your bladder externally. So instead of bearing down and pushing, which a lot of my patients are guilty of doing, and we're trying to correct that, you use an external force to try to empty that bladder. You can also adjust positions, again, leaning over to the left, leaning over to the right, and the center as you're voiding. And it's like again, like you're wringing out the bladder. Some of my patients they feel the stream stop, they stand up, do a little wiggle and sit right back down, and oftentimes can get a little bit more to come out. So, but pushing, breathing, keeping breathing the whole time, and trying not to bear down and push. Now, sometimes mechanical emptying is not really the issue, and we need to do a little bit more behavior modification. So I'm not sure how many of you have ever done a bladder diary, but it gives you an increased awareness of your baseline voiding habits. I just pulled this one offline, but you can get as detailed or as basic as you want, and it could just be writing down times and the feeling, how many trips, how often you're going, the feeling of, am I empty, am I not? You could measure if you want to get really specific, get one of those little hats that sit in your toilet, and it can actually measure the fluid that comes out. But if you're trying to retrain, if your problem is frequency and you want to try to cut down that frequency, you're actually going to try voiding at certain times versus when you have the urge to go. So if you're somebody that's going every 20 minutes, that's really disruptive. And I assure you, your bladder is not full every 20 minutes. So you're going to start, let's say I'm going to go to the bathroom at 6 in the morning, and my next time to go is going to be at 7. So I'm going to try to make it to 7, one hour without voiding. Now you may have urge during this time, and in order to try to increase that time between your voids, you're going to do something called urge suppression. So you're going to stop, you get that urge, I'm going to stop, take a breath, I'm going to do a Kegel and relax and see if that cuts your urge. And if you can buy yourself 5 minutes, 10 minutes, and the urge comes again, and you do the same thing to stop and breathe, do a Kegel, you can get up and you can walk to the bathroom. So the goal is to just start slowly increasing that time between voids and just retraining those bladder sensors to register not when it's 20% full, but when it's 50% full, then 80% full, and then really getting to that point of a full bladder, and then going ahead and emptying without having to run to the bathroom and without leaking on the way. So now the big question is how to do a Kegel. That is not as simple as it might sound. I'm sure many of you, or all of you even, have done a Kegel before. But up to 40% of women can do Kegels incorrectly when just instructed verbally or with written directions alone. So here's some specific written directions for you, but I'm sure you've already done this. Hook lying on your back, finding neutral pelvis, so your tailbone's not too tucked or you don't have too much of an arch in your back. You're squeezing the vaginal, the pelvic floor muscles without squeezing your buttocks. And you're imagining like you're pulling up and in towards your head, those pelvic floor muscles, like you're going up an elevator. And I often will recruit those lower abdominal muscles, like you're zipping up a tight pair of pants. And the goal would then be to keep that contraction and continue breathing. So it feels like you're trying to stop from passing gas or trying to hold in your pee, and make sure you're relaxing in between. these contractions. So there's a couple of actually different types of Kegels. There are slow twitch muscle fibers, your endurance muscles. These are the traditional Kegel. So where you're squeezing and holding for 10 seconds while you're breathing. You relax for 10 seconds in between, and you're doing about 5 to 10 reps and maybe 2 to 3 times a day, whatever works with your schedule, honestly. And then there's the fast twitch muscles. Fast twitch muscle fibers are the quick reacting ones. They often call these the quick flicks because you're shorter, it's a shorter, quicker contraction. Now, these are the muscles that are responsible for keeping you, or the muscle fibers that are responsible for keeping you continent, for supporting those pelvic organs when you sneeze or you cough, and you need that quick engagement of these muscles. So if all this Kegel talk is a little overwhelming and confusing, consider this. Please seek out a pelvic floor PT to evaluate you and see if you're indeed performing a Kegel correctly and if you actually need it. If you've been doing them Kegels and you see no improvement in leakage, or you are not more confident that you can control your bladder, if Kegels are painful and you have persistent pain, it may not be the right exercise for you. And if you're just hesitant to move forward with Kegels because you're just not quite sure that you're doing them properly, I suggest that you don't do them and seek out pelvic PT first. They'll help guide you through this. And along with addressing Kegels appropriately, they'll also likely be performing internal work at some point in time. So there are lots of tiny but mighty little muscles that form our pelvic floor. We don't talk about them a lot. We don't acknowledge them much. I didn't even talk about them a lot in PT school. So they're very important. They don't get a lot of attention unless there's something wrong. So a pelvic PT can help you with more awareness of these muscles, what normal should feel like. And they'll give you specific instructions for home programs depending on your living situation, your specific symptoms, and you'll reach your goals faster that way without so many setbacks. And at some point, they will usually do internal pelvic work to assess these muscles. They may not have to do that every time, but it's definitely still the gold standard. So if your pelvic PT isn't doing it or has not done it at all or refuses to do one, then you might want to seek another opinion. So a poll, again, go to your poll platform. I'm curious how many of you have received pelvic PT to assist with your LS symptoms or comorbidities. So for those of you who missed it, you can catch the replay of Ashley Stump's presentation from day 2. She gets more in depth about how pelvic PT can help you, and specifically with LS. So get your answers in. Okay, like half and half. Yes, didn't know, and then no. I'm actually kind of surprised. Okay. So not only can pelvic PT help with your bladder issues, but it can also help with your bowel issues as well. So let's talk about how we can be kind to our bottoms. So a lot of these are a little redundant with the bladder. Being kind to your bladder, don't rush and don't push. Drinking enough water. That brings us to abdominal massage. So I don't know how many of you are familiar with abdominal massage, but it's really simple. A simple thing you can do at home on yourself. A partner, your kids can help you with it. And this actually helps little kids, babies too. So for our kiddos or teenagers that are having constipation or issues, you keep in mind that the colon runs clockwise, so from the right to the left. So you have gentle pressure in small circles from your right hip bone up to the bottom of your right rib cage, across to the bottom of your left rib cage, down to your left hip bone, and across into the middle, right above your pubic symphysis. So that's the general direction that you're moving in. Not a lot of pressure, just gentle pressure. You can even just rub your abdomen in that same way with big sweeping circles from your right to your left. So a colleague of mine and I did this quick little video that will show you. So hopefully give you a clearer picture.
Hi, so today we're going to show you abdominal massage. So whenever you feel constipated or you feel like something's stuck, you can try this. So what you're going to do, you're going to find your right hip bone and you're just going to start right above it. And all you're going to do is you're going to make little circles in a clockwise direction going up towards the base of the rib. And you want to maybe do about 5 to 8 little circles. And a very moderate pressure, so nothing too heavy. And you're just going up to the base of that right rib. And then once you reach that base of the right rib, you're just going to go all the way across to the left side. And you're going to continue on down once you hit the base of the left rib. And then you're going to go down to that left hip bone. And once you're here, you would start again by starting going up to from the right hip to the base of the right rib, and you could repeat that about 2 to 3 times.
Perfect. So super, super simple. Very effective actually. And in the office, I often will couple that massage with castor oil or like a essential oil. I have a digestive one or lavender, something for relaxation. So you can do that at home too, if that's in your wheelhouse. And so another important topic is fiber. So eating enough fiber, like water, fiber intake recommendations can vary greatly, especially with age and men versus women. So you can use this, I'm sure you have seen this stool chart, the Bristol stool chart, it's called. There's a couple like type 3, type 4, it's kind of what we're shooting for normal bowel movements, and anything that type 1 or 2 would mean you're more constipated. And type 5 and below, there's some inflammation or you're lacking fiber. So fiber bulks up your stools. You can have too much, or you're having appropriate fiber, but then you're not drinking enough water. And that can also lead to constipation. So consider that if you're struggling with constipation, but you feel like you're taking in enough fiber, you may have to look at your water intake. Again, it's age dependent a lot of the times. Adult men, 34 grams of fiber a day is recommended. For women, it's about 28 grams. And for our little guys, kids between 4 and 8, it's somewhere between 16 and 19 grams. So just something to keep in mind. I personally take psyllium husk supplements. So there's so many different fiber supplements out there if needed. And with other concurrent conditions, you might have to just do some trial and error and see what works for you. But definitely be drinking enough water if you're doing an additional fiber supplement. So just like urination, pooping in the ideal position is important. This is my little guy. He wanted to be part of the presentation. So, and he's 5, so he wasn't exactly following directions the best, but that's okay. So this first slide, or this first picture, is if you were sitting, we're talking about the anal rectal angle here. So if you were sitting up straight, that anal rectal angle is the pivot point where the anal rectal junction like kind of goes through the pelvic floor. So if we're sitting up straight, it's about 90 degrees. So that keeps us continent just by physics, biomechanics alone. Now, when we lean forward, like that middle picture, it's straightening out that angle, the anal rectal angle, which helps stool to pass more easily. And the ideal anal rectal angle generally is about 140 degrees. So anything you can do to widen that 90-degree angle is ideal. So help feet flat on the floor, or in this case, a squatty potty. Leaning forward just a little bit, but keeping your back straight. So for him, it probably would have been better if he had his hands on his knees and kind of kept his back straight. But for us adults, we might be able to do it in that position where the elbows are on our knees or on our lap. So there's another study done, about 50% of patients could not empty completely when they were just sitting. And when assuming the thinker position, so the elbows on the knees and maybe even resting the head on the hands, they were able to fully evacuate. So it really does make a huge difference. So I don't know if you guys have had this experience, but try it if you haven't already. Now, the overarching theme, I think, of managing these bowel and bladder issues are also is managing your stress levels. So these are very subjective. It's going to be different for everyone. So I'm curious as to what your go-to stress management techniques are. So go to your poll platform and go ahead and share with us. I think you can type these ones in and we'll see what comes up, because I'm just curious. We've had some really great presenters. I know there was one right before me. And then there's Penny, of course. So if you have access to the replays, go ahead and check her out. I was able to call into the Yoga Nidra one, and it was before work for me. So it was, I'm going to watch that at a later time, right before bedtime. But fantastic. That's what I do. Yoga, breathing. That's what works for me. Gardening, I love it. Work on that. Yes, I do too. Awesome. Oh, I love it. Yes, get your answers in, but see how different, how different all these things are. I'm sure we would like a lot of these things. We would also like it, but that's not the first thing necessarily that comes to mind. But this whole list, everybody's different. So really just finding something that works for you is important. I love these answers. I love hugs too. So get your answers in. And if you are working on this, maybe take some notes as maybe I'm going to try a couple of these things this week to help with stress levels. I encourage you to engage in something once a day, if possible. And we'll end with an easy one that you can do anywhere. So breathing technique. First of all, I'm sure you guys have done and attempted belly breathing. If not, we'll go over that really quick. There's one hand on your chest and one hand on your belly. And upon your inhale, that belly hand should actually rise first and more than your chest hand. So you're keeping that breath in your belly. And then to specifically calm down your central nervous system, you can practice left nostril breathing. I am really just simplifying this, but you can, in the middle of the day, on your drive to work, even if you needed to, you can close your right nostril with the finger and do a slow inhale and exhale through your left nostril. And that directly can calm down your nervous system. You can do 3 minutes to start. That's a good amount of time. And you can get a little fancy with it, and you can do a 4 count. Inhale, 1, 2, 3, 4. Inhale, hold for 4 seconds, and exhale for 4 seconds. And you can just repeat that for a minute or 2 or 3. It's why the left nostril. I see that just came up. I know I don't have to answer that right now, but it's there's so much more science to that. It's very interesting. A lot of it is pulled in from yoga studies and pranayamic breathing, but there are specific connections of what a left nostril breath and a right nostril breath will do in our bodies, and how it can specifically target and calm down systems that we need calming. It's very interesting, but I'm sure a whole nother presentation. So that is it for today. So I would be happy to answer any of your questions that came up. And if we don't have time for all of the questions, I'm doing a Q&A session in at 2:30, I think it is. So you can join us for that too. But happy to answer any questions that you have.
Okay, let me check the Q&A. And I see we've got at least one in there. So first one, having GERD, G-E-R-D, makes drinking enough water challenging. What is confusing is that I'm able to drink 1 to 1.5 liters of water per day and my urine is crystal clear already. So should we aim for color or for volume intake?
I would definitely, that is so variable. So I would aim for the color. Everybody's different. So if you're on that clearer side, I think you're doing just fine.
Okay. Here's a question specifically about PFPT. Does pelvic floor guidance mean that there is insertion into the vagina?
Not always. If you have, a lot of times LS suffers to have painful intercourse and things like that, not just bowel and bladder issues. So I do think at some point there should be some assessment of the pelvic floor muscles, and you can only truly do that with an internal exam. You can do, I guess there's biofeedback, but that's a little bit more they have an internal sensor, but you can also use external pads. And those just aren't super specific because it can pull in other muscles. It can read your inner thigh muscles. It can read your buttock muscles. So it's way more specific if you're comfortable with an exam. Important part is that you are in charge of your treatment though. So if it is something that nope, I don't want to do internal work, then there's ways to certainly work around that. So you are definitely your own advocate. And don't be afraid to speak up. Don't feel pressure to do it, but it is still considered the gold standard. And I'm also trained, which I know a lot of other pelvic PTs are also trained in visceral manipulation. So it's actually the movement of the organs, working on restoring the intrinsic movement of the organs. And if I'm working on the urethra and the bladder, I can access that externally with just intention. But I can also mechanically do it by manual with a hand internal and then a hand at your belly, above the bladder and the urethra. And it gives me, I feel like I can get more 3D release, of the tissues. So I incorporate internal work a lot because it's another area that I can address, a deeper area that I can address. But again, it's definitely your treatment and at your comfort level. So that's the most important thing.
Okay. Our next question. So sometimes when stretching my inner thighs or breathing into my pelvic floor, as we learned this week, I think butterfly pose is the one I'm familiar with. Just that was my commentary. I feel an urge to urinate, but I don't actually have urine in my bladder. Is there an explanation or is our brain just being tricked?
Kind of both. Again, going back to like the overdrive in the ANS, the overdrive sympathetic nervous system. So your brain is always tricking you. I gotta go. And there's that fascial connection with that stretch, that inner thigh to the abdomen. So if you're directly stretching, if you're feeling this during a stretch, there can be a fascial piece that needs to be released, that when that is released, you won't have that urge anymore that's being triggered by that fascial connection. Does that make sense? So there could be a couple things going on. Again, working with a pelvic PT, working with a massage therapist even that does myofascial work, that could be really helpful.
Okay. So our next question, I've heard that rebounders could help strengthen pelvic floor muscles. Do you use these in your practice?
If somebody has it, I love rebounders. And when we're now, I've had people say, I'm using a rebounder, I'm using my son's trampoline or something, and they're bouncing. Rebounders are very gentle. You don't have to come up off of it. So again, possibly working with a pelvic floor PT to address specifically what you're dealing with, and then instruction on how to use these tools. That really helps with lymphatic flow, blood flow. I do love rebounders, and it can give you just enough uh, stimulation pressure for you to kind of engage the pelvic floor very gently. So I do like rebounders, but like any workout, I think it's, if you're unsure, I think it's best to get a little bit of guidance from more of an expert, and they can actually look at you, look at your technique and how you're doing it. I'm also, if you don't have a rebounder already, I'm not a huge proponent of like, oh, you got to go out and buy all these things. I just want to make sure that that's going to work with your lifestyle. If the patient tells me that that's what they want to try, by all means, go ahead and do it. But I try not to say go out and buy all these things when you're going to buy it and you're not going to use it. So very dependent on the person and their situation.
Okay. So our next question has a medical term I'm not familiar with, so I hopefully will not butcher the pronunciation. So for those that have a history of vesicoroidal reflux, or where urine goes back into the ureters, are there things to keep in mind for pelvic floor PT, like doing Kegels? This person is starting PFPT for the first time next month.
That's awesome. Yeah, I guess it would. So definitely looking at the reason why that's happening in your specific case. Were there surgeries? Is it just kind of like something you were born with? Were there surgeries abdominally, around the bladder, around the urethra, around the ureters, that there's a scar tissue kind of component that might be causing that reflux? So again, I think your pelvic, I would defer to your pelvic PT. Kegels, I'm not sure that would be the best thing for you. Again, I can't really I don't know your whole situation, not giving medical advice per se, but just the fact that you would definitely have to watch that. It wouldn't just be as simple as, oh yeah, go ahead and do Kegels and it's going to be just fine. And then also looking at that potentially other tissues, that fascial component, and if that's causing some of the reflux or contributing to it. That kind of fascial pull can contribute to GERD. It contribute to reflux elsewhere. So why wouldn't it possibly contribute to reflux there as well? So if they can kind of tease that out and see if there's a component contributing to your symptoms, that would be really good.
Okay. They did post a follow-up clarification. It was a condition they were born with.
Okay.
And then they did have dilation done, and it's resolved.
Okay.
So.
Oh, good. Great. That's awesome. Definitely share that with your pelvic PT though.